Okay, we have two presenters joining us here this morning. Jessica Grabowski is the Executive Director of CCA. Jenny Winkler is a Director of Safety, Quality, and Health Policy at IHA, where she works with hospitals to support and enhance their patient safety and quality work. And with that, I'd like to turn the floor over to Jessica and Jenny. Welcome this morning.
Thank you. Thank you so much for having us. This is Jessica Grabowski with Coordinated Care Alliance. Today's objectives include examine the implementation process of a broad-spanning population health initiative involving healthcare entities and CBOs. And today we're specifically going to be looking at examples from Illinois that utilizes hospitals and the aging network. You're going to learn to understand the impact of the social determinants of health on overall well-being and the prevalence and how the aging network can address these needs. Evaluate critical quality and improvement strategies used to establish goals, develop action plans, and evaluate the program. And you're going to learn how to replicate this best practice using our playbook. So we do have a playbook that's developed, and at the end of the presentation you'll find our emails, and if you're interested, we are more than happy to share that playbook with folks. So once again, my name is Jessica Grabowski from Coordinated Care Alliance. Coordinated Care Alliance is a statewide network of community-based organizations in Illinois, really focusing on the 60 and up population and individuals with disabilities. So the folks, the members of CCA, we have 26 community-based organizations, and they are the care coordination units in Illinois. So the aging network looks a little different in Illinois, where it goes from the state agencies on aging to the area agencies on aging, which are the AAAs, which most states stop at that level, but we go one layer down to the care coordination units, and they are the ones that are actually boots on the ground in the home of older adults, providing services, completing care plans, connecting folks to homemaker services, and so forth. So that's the group of folks that formed Coordinated Care Alliance in 1998. And so CCA really represents the private arm of these organizations, where we contract with payers, hospitals, skilled nursing facilities, and so on. So just a visual representation of the delivery network for Coordinated Care Alliance. And the programs that we provide are overall care coordination, transitional care services, the evidence-based bridge model of transitional care, and specialized programs. And today's program, what you'll learn about, falls under the specialized programs bucket. And now I'm going to turn it over to Jenny from IHA for an overview.
Yep. Hi, everyone. Thanks, Jessica. My name is Jenny Winkler. I'm Director of Quality, Safety, and Health Policy at the Illinois Health and Hospital Association. And our organization really is the resource and the voice for just over 200 hospitals in the state of Illinois. So we've had the ability to partner with Jessica in Coordinated Care Alliance as a result of our work through the Great Lakes Partner for Patient Hospital Improvement Innovation Network, or the HIIN. So this program was funded through a CMS contract, where we were working with hospitals across the state of Illinois to achieve a 20% reduction in various hospital-acquired conditions, including falls, adverse drug events, infection prevention, as well as a 12% reduction in 30-day readmissions through the various interventions that you see listed on this slide. With the goal of reducing 30-day readmissions, we teamed up with Coordinated Care Alliance to develop this enhancing partnership to address the social determinants of health program. So I'm going to turn it back over to Jess right now. She's going to give you a little background about why we felt addressing social determinants of health was an extremely important piece to impacting readmissions.
Thank you so much. Just to set the stage again a little bit is why we developed the program. And we developed the program because, as we all know, I'm preaching to the choir here, because of the changing healthcare system. And I love this quote that says, if what we are paid is based on the outcomes we are able to produce, it begins to shift the focus and realization that we need to begin to make investments in those issues that, while not traditionally healthcare related, have such a huge impact on health. And what Richard was discussing or mentioning were the social determinants of health. So previously folks did not believe that these were necessarily healthcare related, but through research from the past couple of years, we know the big impact all the social determinants of health have on health outcomes, including mortality, morbidity, life expectancy, and so on. So research shows that about 20% of your overall health comes from the healthcare that you receive. The rest are because of the social determinants of health. So for example, if you went to the hospital, you received the best care possible, but then you go back to your home, your physical environment that has mold, and you're also a smoker and you start smoking again, the probability of you going back to the hospital is quite high, and that has nothing to do with the health care that you received prior to your discharge. So those are the social determinants of health, and research shows that 40 to 50% of readmissions are related to those psychosocial problems, and that is exactly why we feel it's important that healthcare, we need to build this bridge and enhance the partnerships between healthcare and community-based organizations who are able to address these social determinants of health and be able to be those eyes and the ears in the community for the healthcare system. And so prevalence is really important to look at as well. So one academic medical center assumes the screen positive rate for basic resource needs would reflect the clinic's Medicaid population, which is just under 20%. The reality was that 58% of screened patients had a positive screen for basic resource needs. And this is really eye-opening. From my standpoint, when we do these workshops, people are blown away by these statistics. One individual even said, I don't believe this. This doesn't happen in our community. We don't have that here, which this is a huge cultural shift to be able to acknowledge this, and then also acknowledging that the healthcare system does have to impact this if we want to look at outcomes, if we want to make reduction in readmissions and ED visits and observation stays. We have to look at the whole person and the whole person's needs to be able to address everything, all of their needs for that individual. And so once again, the Care Coordination in Illinois provide home visits, and they are a valuable resource, they have valuable information that the healthcare industry needs. The healthcare system who's unable to go into the home won't know that the person doesn't have food in their fridge, or that they go to McDonald's every day for lunch and dinner, or they're a fall risk because of all the stairs in their home. So being able to partner and bridge these two entities is exactly what we knew we had to do. So the program goals include enhancing the partnership between the hospital and the healthcare systems and CBOs, educating both partners on programs that benefit individuals in the community. Just as much as the hospital had to learn about the community services, that healthcare industry also provides a lot of great resources and transportation and so forth. So the exchange happened both ways. Identifying targeted priorities and action steps based on the social determinants of health. And Jenny will get into this, but we really had a very deliberate way of them identifying their priorities based off of this opportunity assessment that we developed. And then looking at the streamlining referral processes, including identifying and referring individuals with the need to the CBO, and looking at that referral process as a whole. This doesn't seem like rocket science, but because we are making big system change, all of these steps are very deliberately laid out in our playbook and in our program, because they seem so obvious that folks actually don't end up looking into them. So for example, we had a hospital that said that they did a warm handoff for that social determinant of health need. They provided a warm referral to the CBO for connecting that individual to services. When after 3 months, we noticed we still weren't getting the acceptance rates that we needed or that we thought we should be receiving from patients, and we found that their warm referral consisted of just printing off the face sheet and giving it to the CBO, and then the CBO would go into the patient's room to discuss these services. Well, the patients were caught off guard. They had no idea who they were and why they were there. And the CBO did not have all the information in their back pocket to be able to bridge that gap. So a warm referral process does take a lot of looking into, discussing what that looks like, what is the wording there, and that's what our program really gets into to ensure success. And so our program delivery, we've done this program a couple of different ways, but to date we have had 40 hospitals and 20 community-based organizations go through this workshop, go through this program. And so the first type of approach we had was one hospital system and one community-based organization that we worked with for 4 months, really high touch. Then we really wanted to expand this a little quicker than that. So we looked at one healthcare system, which included 14 hospitals and 9 of their community-based organizations or their care coordination units. And then we also implemented these meetings regionally, so we had multiple different types of hospital providers from different types of systems and their CBOs present. And all of these iterations, all of them were proven to be successful. We also have this playbook, so you are able to pick this up yourself and approach a hospital. And something to note is we are today talking about partnering the Aging Network with the hospital, but we wrote the playbook in a way that it could be any community-based organization. So if you are a mental health provider, you could approach your hospital using this playbook. You could also approach a skilled nursing facility. So healthcare entity is used interchangeably for either a payer or a hospital or a skilled nursing facility, and the community-based organization, it could be a vast variety of community-based organizations. We actually are now looking to expand this program to work with skilled nursing facilities and physician practices, and we've also received folks from the payer side that are interested in this work. So this was purposely done in a flexible way so folks could use this in their settings. And we've done this with hospitals in rural settings, critical access hospitals, and big hospitals in the Chicagoland area, and all of them have been proven to be successful. So now I'm going to turn it over to Jenny, who is really going to walk you through the playbook and the program itself.
Great, thanks, Jess. Yeah, everyone, so I'm going to take you through the playbook that we had put together, just so you get a feel for some of those deliberate steps that Jess had mentioned and how we tackled this work. So again, through our experience, we were really able to take those best practices and lessons learned and develop this playbook to support any type of healthcare facility or organization, community organization, with implementing the same program. So our aim with developing this was to create a digital resource that had a different look and feel than your typical toolkit. We wanted something that organizations can pick up and read and then start working with right off the bat. So we're going to go ahead and just dive right in. So the first page of our playbook really lays out the key players that were involved in this work. And so as you can see on here, there's a couple sentences about IHA and Coordinated Care Alliance here, but we've also included information about healthcare facilities and community-based organizations. And so reading through this will give you an overview of how those organizations really participated in this work and examples of the roles from each one of those facilities that would play a part in this program. The next page of the playbook is titled Our Why and Our What. And this is, again, additional details around the background, overview of the project, why addressing social determinants of health is important, and really how you can use this as a tool within the different organizations. The next page of the playbook gives more instruction on how to actually use it. And so, again, by working closely with CCA, with hospitals, with care coordination units, we were able to nail down or identify 3 different phases that were used to successfully enhance the partnership between the healthcare facilities and the community partners. And so within each of these phases, there's a handful of key activities that should be completed before moving to the subsequent phase. And so I realized the font may be a little small on your page, so quickly, at a high level, the first phase of this work really was about looking at your internal organization, identifying resources that internal organizations have, or then taking a look at what's out in the community, and identifying what's existing, identifying, the key partners that you actually want to work with to enhance the referral process. So doing a lot of that pre-work, internal work. The second phase of this work really focuses on the collaboration piece, and this is where the healthcare partners and the community partners come together to identify opportunities for collaboration and then work to develop action and deployment plans to help them succeed with improving their referral process. And then the third phase of this work is really about, continuing that momentum, continuing to work together and evaluating and refining the processes that you determined or that you worked on to develop in phase 2. And so we're going to take a deeper dive into each one of the different phases, but a couple things I want to point out about how our playbook is laid out. So on the top left of each one of these phases, you'll see that there's a video that we have that kind of gives a high-level overview of each of the specifics of the phase. And then on the right-hand side of the page, there's key steps, and this is kind of what Jessica had mentioned, and this is what organizations will walk through and complete before moving on to the next phase of this work. And then on the bottom left of the playbook, we have a list of resources and links to those resources that will support organizations as they walk through each one of those key steps. So another piece that's really great that's integrated in our playbook is we have comments and small nuggets of wisdom that came from the various organizations that have already experienced this work. And so, reading those are really kind of some nice tips and tricks for how to move through the key steps. And while I don't have this on the page, there's also subsequent pages in the playbook that list keys to success for each one of the phases and challenges that might be encountered and some strategies with overcoming those challenges. And so with that, I'm going to take a deeper dive into each one of these phases just to give you a sense of how this program really came together. And so as I kind of mentioned, the first phase was really about taking a look and identifying gaps in organizations' internal resources, and then identifying gaps, external gaps in resources that might be out in the community. And so, we encouraged the organizations we worked with to really start by thinking through what their patient or what their client's individual needs are, and then using those needs to work with the leadership in their organization and make a case for why enhancing the partnerships are so important. And then again, starting to establish the connection and the partner and the relationship with the organizations that you want to partner with. And a lot of times healthcare facilities and community organizations already have partners or partnerships that exist. So really honing in on who you want to team up with and to enhance and improve the relationship that might already exist. And then finally, the last piece of this phase is really laying out what your organization's internal resources are, what's available. So on the healthcare side, looking at what resources they have in the hospital, and then again out in our community partners, what resources they have available that might be beneficial to the hospital. And so doing this internal scan and identifying the lay of the land within your own organization before getting together with your partner organization is really essential, and it sets the organizations up for success as part of the next phase. So jumping into phase 2. So this is really this is a bulk of the work, and this is where our healthcare facilities and our community partners come together to either develop or enhance the relationship they've already had, and then start working together to outline opportunities to increase and improve the efficiency of the referral process between our organizations. So phase 2 is in the past has consisted of an in-person meeting, but we know with the challenges nowadays that moving forward this might be a virtual meeting, but really it is where organizations come together, where they share the work that they did as part of phase 1. Then they work together to identify specific social determinant of health, a patient population, and a referral process that they want to improve. And so, as I mentioned before, a piece of this is we have tons of resources included in the playbook. And what I want to do right now is walk you through some of those resources that will support this partnership meeting and kind of hone in and help with this work. So as Jessica had mentioned, to help organizations really review their resources and referral process, we put together a tool called an opportunity assessment. And so I apologize again, it probably appears pretty small on your screen, but on the left-hand side of this assessment, there are various statements that relate to specific social determinants of health. And so a couple of examples of those statements include an individual feels loneliness or expresses feelings of loneliness, or an individual eats most of their meals alone. So you'll see there's corresponding there's boxes to the right of each statement. And in the boxes, so a healthcare facility will answer whether they always, sometimes, or never have data to identify these patients, and if they have a process to connect these patients to their community organizations as it relates to each one of those statements. And for those same statements, our community organization will answer whether they always, sometimes, or never have a process to either accept or refer those individuals to services. I know that was a lot, but really this assessment is a great way to guide the conversation. So when the healthcare organizations and when the community partners come together, they're able to identify strengths that they have, existing supports in the community, and then areas of opportunity where they're going to focus their work regarding social determinants of health. And the other great part about this assessment is that it really gets deeper than some of the general screening questions that are asked, especially in hospitals. So it's really a way to identify some of those gaps for individuals in the community. Prior to meetings, we encourage organizations to fill out the columns that are applicable to their care settings, so that way when they come together, each organization will have an opportunity to share the information that they've learned, and then everyone can compile their responses in one spot. So it's easy to identify what social determinant of health needs to be addressed in the community. And the next, oops. There we go. So with that, so that's the first resource. And once the organizations work through that first resource and kind of identify the social determinants of health that needs to be addressed, then they can start thinking through the referral process for that specific social determinant of health. And one of the resources we have available to do that is called a SWOT assessment. And SWOT stands for Strengths, Weaknesses, Opportunities, and Threats. So after identifying the social determinant of health and focus, we encourage organizations to start thinking about the referral process and kind of use this as a guide to, or a tool to map out what they feel their strengths, weaknesses, opportunities, and threats are in the current process, and then use this as the basis for some of their discussion. So as we move through that partner meeting, the next piece we work with facilities is on mapping out their actual referral process. So on this slide, we've included a couple of examples that organizations have done when they're mapping out their referral process with Post-it notes, and encouraging them to be, of course, as detailed as possible. So that way we can delineate the different steps in their referral process and who's responsible for each piece of that process. As we've learned, or as we've done this a handful of times, we've put together a list of questions that we encourage organizations to think about as they're mapping out their referral process. just as a way to kind of jumpstart and get the thinking going. Well, another big piece of this partnership meeting is really identifying opportunities to improve the referral process. And so using the Model for Improvement, which is a quality improvement methodology, as our guide, we developed this action planning document. And so what this is a resource that's a living document which changes regularly, but it's a way to give the healthcare facilities and the community organizations a blueprint to follow so that they can hone in on which social determinant of health they identified and that they're going to work to address. And because this is a blueprint and such a staple in how to improve the referral process, I want to take a couple minutes to walk through the different sections of this document. So the first piece of this action planning document focuses on the development of an aim statement. And developing an aim statement for this work is really important because it solidifies the goal that you're trying to accomplish. So there's some tips and tricks that we include on here. We encourage organizations to make something that's time specific, measurable, it defines a specific population. And so here are some examples of aim statements that the organizations we've worked with have come up with. And so as you can see when you read through these, it's very clear the goals that these facilities were trying to accomplish. And so the aim statement really sets the stage. And so moving through that action planning document, another piece of the action planning is measurement. And so measurement is important because, once you make a change in your process, this is how you're going to demonstrate whether or not that change has made any improvement for the patients or the clients you're working with. And so, again, it's a little small, but on this slide there's examples of different measures that some of the groups we worked with came up with and are applying to their work. And like the aim statement, an important piece of developing measurement is ensuring that it's specific and that your goals are realistic. And so the third piece of that action planning document is really dedicated to deciding what changes that organizations were going to make to their referral process. And so the different changes you want to make in your referral process are called change ideas. And so a few things, we encourage groups to consider as they're thinking through what changes they want to make in their referral process are whether or not there's opportunities to improve workflow, are there opportunities to improve time management or streamline processes and prevent any duplicative work between the organizations. And so again, this slide lists some of the examples that the groups came up with, including a warm handoff, implementing a process for warm handoff, using a tracking tool between the organizations, and then also developing patient education tools. And again, as we encourage and as we work with organizations through this, we encourage everyone to start small and aim for those small wins, because sometimes it can be very overwhelming with trying to, grasp all the big changes and try to tackle everything at once. And so with that, in addition to the action planning document, this is another tool that we've included in the playbook. It's an example of a tracking tool that healthcare facilities and community organizations can use just to improve the communication between the organizations and to help support that closed-loop referral process. And this, again, is just an example. This is a slide that demonstrates the model for improvement. And as we're, this is a strategy we're using as the framework for helping organizations improve their referral process. So the last phase of this work starts after that partnership meeting. And really, this is where organizations will continue to work together and continue to move forward, reviewing their newly established referral process. So we encourage organizations to continue to engage, whether it's through phone calls, in-person meetings. We encourage them to use the action planning document, since that's the document that they came up with together during their partnership meeting. That's really the tool that they can use to track their progress, and kind of serve as the center of the discussion during the subsequent meetings. Phase 3 is something that's meant to be continuous, and is something that will continue in an ongoing fashion. So, once organizations work together and they come up with a solid referral process that's making improvements for their patients, we encourage them to go back to phase 1 and actually tackle this process all over again and either expand on their current work or identify another social determinants of health as an area of focus. And so to support the implementation work, another tool and a resource that we've included in here is a sample implementation plan. And this just helps with delineating roles between healthcare facilities and community organizations just as they're getting started with the process. And a couple things that we encourage organizations to consider as they're working through this is really identifying champions, somebody from the hospital, from the healthcare facility, somebody from the community organization side, continuing to schedule meetings and continuing to work together and keep the momentum going, which is something challenging, as we return to our day-to-day work. So with that, I'm going to pause. I'm going to turn things back over to Jess, and she's going to share some of the successes and key learnings that we've had throughout this work.
Thank you, Jenny. So some of our successes include just the overall increase in education at all levels across the care continuum. So the folks that come to the meeting are obviously decided by the hospital and the CCU, but we did provide some guidelines and guidance where, from the CCU perspective, as the Director of Social Services, the transitional care folks. In Illinois, we have Choices for Care. These are folks that are already at the hospital providing choices for individuals to essentially educate them about the services in the community and letting them know it's not just skilled nursing facilities. They're only option post-discharge. So we recommended those folks come, as well as the executive directors or CEOs. And from the hospital perspective, we asked that the Director of Social Services, administrators, directors of quality, nurses, social workers, PT, OT, physical therapy is really critical because they're the ones that make the decision if somebody should go to a SNF. But maybe if they knew of the resources in the community, it wouldn't be such a quick decision to have somebody go to a skilled nursing facility instead of home, including any ACO participants or transitional care folks that they have that they wanted to bring. But from that, quickly folks learned that they needed to take this education and educate folks in different departments, including the ED, acute. This hospital had a post-acute facility on site as well as a clinic, so they educated all of those different folks in the care continuum, educating providers, nurses, case managers, social workers, doctors, chaplains, transitional care staff, post-acute liaisons to skilled nursing facilities. We found an increase in referrals, an improvement in the referral process, including warm handoffs, closed-loop referrals. Folks looked at referrals for the weekends versus the weekdays. What happens if you have a referral in the evenings? Really looking at all of those pieces to make sure the referral process is correct. Maximizing programs. So we found that there was a hospital and a care coordination unit that both had caregiver programs, and neither of them knew of it, even though they were in the same city. So they decided together they would map out what both of their programs do, and they weren't going to duplicate programs on the same day. They were going to cross-refer to maximize essentially the benefit and services to those caregivers, as well as identifying issues with current programs and developing community solutions. So I'm going to share one quick example of this. So this hospital was working with essentially a national home delivered meal company. Well, the area was working with a national home delivered meal company, and this changed from using a local home delivered meal company to a national one. And this national one started to deliver meals one time a week versus daily, and would provide 5 meals total in one go. And so the issues that occurred were that these patients no longer received daily checks. They were unable to pick up all their meals. Some folks didn't have room in their fridge. Meals were not warm each day. Folks with dementia weren't essentially reminded to eat their lunch at a specific time. And so then the hospital and the community-based organization looked at this, tackled it together, and solved this problem with various solutions. So outreach workers from the Senior Service Center would call folks every single day for that friendly reminder or friendly call. If somebody did not pick up, they actually further collaborated with their sheriff's department, who did a well check program, who would actually go out into the community. And the CBOs had some financial support for bigger fridges if needed. So they were able to look at this one big issue that was happening in the community and solve it together, maximizing resources that they were able to look at together. And some successes continued. We worked with a rural hospital. Prior to program implementation, the hospital was referring 0 cases. After the program, they are referring 100% of their older adults at the acute setting, subacute, and they also educated the clinic doctors, and the doctors are now referring if an older adult comes in for an appointment and needs are identified. A large healthcare system in the Chicagoland area, only 2 out of the 14 hospitals actually referred to the CCU for services. After the program, 100% of the hospitals have personalized action plans to identify social determinant of health needs in their community and are referring to the CBO. We had 100% satisfaction from both hospitals and the community-based organizations who attended the workshop. Once again, that's 40 hospitals, 20 community-based organizations, and we were supposed to actually continue this work and have 2 more workshops under our belt by now, but COVID hit and has definitely impacted some of our work right now. So, and then key learning. So start small. I think the biggest problem we find is that, unfortunately, the community-based organizations say, we do it all. We do everything for the older adult. And there will definitely be times that you're unable to meet that, and then the hospital gets discouraged, or it's just too wide. And when you're in day-to-day work, specifically in the hospital setting, when a social worker has all these things going on, they're not going to always just refer everyone 60 and up to the CBO. So making sure you target a small SDO intervention with a small scope. So starting with maybe 1 unit or 1 social worker, looking at home delivered meals, asking 3 questions, and if somebody answers positively to that, you would refer to the CBO. And then you could work out the kinks in the referral process, any kinks in what information needs to be sent over. Also, the CBO doesn't get flooded with referrals that they can't do anything with. And then once that works well, you could expand that to maybe another floor, another social worker, eventually where it's for the whole hospital, depending on the size of the hospital. Once that is tackled, then maybe you could focus on transportation or social isolation. So really making sure that you start small. Constant communication back and forth. Being able to use systems that kind of talk to each other. We use this web-based Excel document so folks could see quickly what was referred, what happened with them, closed loop referrals so the hospital knows what's happening. And make changes as necessary, expand and narrow as needed. So the model improvement uses this PDSA, Plan, Do, Study, Act. So every week there could be little tweaks to the process. And that is why you want to start small, because you don't want to make changes for 20 social workers every single week. They're just going to be frustrated with the situation and then not refer. So making changes, making sure you do make the necessary adaptations so this is successful. Not not keeping a process for a month, even though you know it doesn't work, just because you don't want to change anything. And really the key to this is that this is not just a regular conference. This is a workshop. Folks came in initially to our program workshop thinking that they would just listen in, they got their information, they would go home and everything would be the same. No, we're making change. This is cultural change, this is daily change, this is system change. And so knowing that change is what is the end result is really important. And with that being said, really highlighting a champion to be able to monitor the program or the referrals on a daily, weekly basis. Unfortunately, we found that folks do come to the workshop, then go home, go to their shops, and then they do business as usual. So it was really nice that we were a third party looking in and being able to say, hey, where are we with referrals this week? It looks like they're pretty low. Oh, and that just jogs people's memories. Oh, yeah, I'm supposed to refer for those home-delivered meals. If you also have a champion, you also have a natural person that is essentially building buy-in to the program, which is important because, once again, it's cultural change. Some folks may not want to expand their duty to other things that they have to manage for patients. So being able to have that champion to build essentially the program up and folks, the participation into the program, ensuring that you have you're set up for success right from the beginning. And with that, we are ready for questions. But I do want to just pause here that you'll have, these are emails. If you're interested, we will send a link to the slides. I'm sorry that the link in the PowerPoint wasn't working. We'll send the playbook with the slides, but also if you have any more questions, feel free to email myself or Jenny. And also if you're interested in further collaborating and having that outside voice helping with this process, because sometimes it is nice, once again, to have that third party being able to push this forward with efficiency and to ensure success. We are happy to discuss that with you and see what that would look like for your organization.
Okay, thank you very much, Jenny and Jessica. And yes, everyone, it's time to move into the Q&A portion of the webinar. So send in those questions for our presenters here. And presenters, let's just jump right into it here. The first question for you, why is isolation not included in the social determinants of health?
So that actually came from, let me just pull up the slide that you were mentioning. And this comes from a body, and I believe they were thinking that it was going to be under social integration. But yes, I would, it would be very nice if that was just laid out completely, as we know the importance of social isolation and its impact.
Okay, thank you. Next question, how do you handle client data sharing in a multi-agency collaborative like this?
So once again, in Illinois, the Choices for Care folks through the CCU, the care coordination units are already on site at the hospital, and it is their duty to assist in that transition. So for that, the hospital folks are able to refer to the Choices for Care individual that's on site, and that's actually why we started with the care coordination units. But also they do sign, patients sign confidentiality, release of information forms for us to be able, for the CCU to be able to talk back to the hospital with that outcome. So there definitely are releases.
Okay, next question. We hear a lot about going upstream to address fundamental inequities best addressed through policy change, things like financial instability and ageism. Does this program get engaged in policy interventions at the community level?
I think both of our organizations are involved with policy efforts. This program was developed really for that programmatic piece, but Jenny, feel free to jump in as well.
Yeah, and I would say we can understand the challenges, and that policy intervention is really important in some of these situations. But like to Jess's point, we really engaged with the hospitals and the community organizations as far as what they have access to and what they do control, or what they can control.
Okay, thank you very much. The next question: how were agencies and healthcare providers motivated to get involved in the Alliance? Example, what is in it for them?
I can say from I can say from the hospital perspective, we know more and more research is coming out, and Jess has talked about this in the beginning of the presentation, that, addressing social determinants of health is key in reducing 30-day readmissions for hospitals. And so hospitals from our experience in Illinois, have been very interested in this work and are very excited to participate.
Yep, and at the care coordination unit level, these organizations exist to be able to provide those home-delivered meals, homemaker services, and what have you. So it is their best interest as well to have a really good relationship with hospitals and healthcare entities in their area, so they could continue to address those needs for their older adults in their communities.
Okay. Next question: with COVID-19, many community-based organizations have experienced a drop in donations. Can healthcare facilities provide funding to partnering CBOs?
Jenny, I could jump in, but then I'd love to hear your perspective as well.
Sure.
From everything I'm also reading, COVID is directly impacting hospitals, very much so as well. We believe that this could be like that first program that enhances your relationship to hopefully be able to look at how dollars are spent. That, yes, let's say home-delivered meals is a huge need in our area. Maybe this is something that the hospital could help fund as well. But this program in and of itself was designed to essentially get funding from the hospital right away, at least. But maybe the first step.
Yeah, I would agree. Yep, nothing to add.
Next question: are there any recommendations for how to code or track in systems to link referrals and referral competition to payments?
We have not had any experience with that, or received any feedback from the organizations we worked with, but happy to pose that question to see if anybody has implemented a strategy that does that.
I have heard of some healthcare systems that do code out which referrals and what have you that they make on behalf of their patients, but once again, we did not work with any of our hospitals on that specifically.
Okay. Next question: what cultural changes are needed most, and what is the role of telehealth monitoring?
From my standpoint, just the realization that social determinants of health are not going away. This is the reality now. We know that they impact the health outcomes, and how do we get everybody on board? I think at the administrative level, a lot of hospitals are hearing about this. Then folks are told that they have to screen for this, but I don't know how much buy-in is really there at all the levels, really on the ground, boots on the ground, that are doing this day-to-day work, because if they are going to address these social determinants of health, it does add another huge layer to their work. And what does that mean for them? Are they able to achieve that? What are the time constraints? What are the resource restraints? So looking at this big picture and making sure that we have buy-in from all levels. And for telehealth monitoring, I think it's a huge need. And so I think that is another thing that could be, if you're a community-based organization that is offering that, and you notice that there's a need that the hospital has, is essentially pitching that as well. So the opportunity assessment that we developed was specific to what the CBO, what the care coordination units could be able to address to the healthcare entity. So if you're not an aging network provider, or you have services that expand a lot more from the typical aging network services, then we would suggest that you expand on this opportunity assessment with the specific things that you're able to address to start that conversation.
Okay. Next question. I'm dealing with COVID-19 barriers, services suspended or lacking volunteers, to ensuring frail and at-risk clients get meals, wellness checks, and medical appointments. Lack of technology for telehealth. Do you see this as a trend, and how do you address this in senior populations living alone with health issues and limited income?
Yeah, I think it really depends on each community. Each community is so different with the resources that they have at their disposal, and how much they're impacted by COVID today versus, a month ago versus what's going to happen in a month. I think there is going to be a new reality of how we work and the adjustments that we're going to have to make in our day-to-day services that we provide. Making them more telephonic or webinars or what have you, but still figuring out how we could provide those safety checks and those in-home resources for older adults. But I think it really just depends on where you are in the services that you provide and what that means for you. I'm not sure if I could be more helpful right now without knowing more information, but I'd love to connect with you offline.
Okay, next question. For communities that don't have the appropriate programs to which healthcare providers can refer to for a particular social determinant of health, could part of the partner process include designing programs?
Yes, definitely. I think if your hospital is open to that, I think that's a wonderful idea. So figuring out what are the needs in the community, what you can do together, how you could be innovative, and seeing what that means. Does that mean you first start with a grant to get this funded? If it is successful, maybe then the hospital would be able to put some dollars to it. But really starting that conversation with the healthcare entity to see if there is interest.
Okay, what incentives have been successful in terms of getting staff to adhere?
And Jenny, feel free to jump in. From my perspective, It's really having those champions at the administrative level, being able to inform them why, and that's why we want to level set at all of our workshops, why this is important. It's not just another thing that we're putting on your plates. And then really having those cheerleaders and sharing best practices as well as case stories. Once you get one or two cases which shows the huge impact you've made by making that referral, I think people come on board.
Okay, next question. How do the CBOs negotiate funding from the partners?
Once again, this is, I think, very locally specific. There's some hospitals that have foundations. There are opportunities where you would first get a grant to show your outcomes and then be able to provide those outcomes back to the healthcare industry. But I think everybody's hoping to knock on, you know, the doors of healthcare, but knowing that also not all of your programs are going to be something that the hospital is really in need of, because they don't correlate specifically to their needs, reducing readmissions, reducing ED stays or observation, or increasing satisfaction. So knowing which programs you can present to them, and then being able to present outcome data that really ties into actual cost savings that the healthcare industry is going to obtain.
Okay, next question. You have concretely addressed issues that I have seen occur in Pennsylvania and provided a possibility of a way forward. I know one challenge will be getting the hospital to give us information about patients in a timely manner. Does the playbook address this issue?
So I think, go ahead. Okay, I can see. So I think that is a good question, and it kind of gets to the heart of the goal of all of this work, is by really starting to work with the hospital, work with your hospital partners, and kind of starting that conversation, and then working together to come up with a process so that the community partners and community organizations get information in a timely manner is key. There might be maybe there's some IT challenges that maybe from the community end you're not aware of, or there might be some workarounds that organizations can come up with. But you know, I think you know, it's a great starting point to have that conversation with the hospital and work together to address that issue.
Okay. Next question. Have you worked with any patient-centered medical homes, as some hospitals refer patients to these organizations to help provide services and ongoing care?
We have not worked with patient-centered homes at this point. We were first targeting hospitals, but now we do feel like we're in a place that we want to expand this. So that's definitely a great idea. Thank you.
Okay. By the time a senior connects with the hospital, we have missed many opportunities to keep people healthy and independent. Can this be moved to the primary care, specialty care, FQHC level, and seen this as providing services as preventative services?
Definitely, definitely. And that is why we want to expand to PCP practices first. So obviously partnering with IHA, the focus is hospitals, but I think this is a great opportunity to take this to the preventative arena with the PCPs. That would be very exciting to me. And I would love to hear about it. So if you do it, please let us know.
Why are families not being referred to the public health department that are already familiar with community resources in their area?
I think it really just depends on the area. So the care coordination units in Illinois have this role. There's definitely a role for the public health departments, but really the CCUs are already on site at the hospitals in Illinois. So I think it depends on where you are locally and the resources that the public health department provides in that area. But I think this is a great idea as the public health department to partner with your healthcare entities, once again, be it hospitals, SNFs, or PCP practices, whatever it is, so they are knowledgeable of these resources. Quite honestly, what we're finding, and just like the statistic said, healthcare entities just don't know. So they may not be knocking on your door because they don't know the services that you could provide. So that first step is that information exchange that happens in the first meeting, which you'll just see light bulbs happening the whole time going off because they're unaware of all the resources that are available to them and to the patients.
Okay, well, Jessica and Jenny, we have reached the end of our hour here, and unfortunately we're out of time, but I want to thank you for joining us this morning for a great presentation. Thank you so much.
Thank you.
Thanks.